So I'd like to welcome Professor Hassan Shehata, who is the RCOG Senior and Global Health Vice President for South West London and Surrey Heartlands. Is a South West London and Surrey Heartlands Maternal Medicine Network Clinical Director and Epsom and St Helier University Hospitals Maternal Medicine Obstetric Consultant. And Professor Hassan Shehata is going to speak to us about understanding the use of vitamin D supplementation in pregnancy, the role of risk assessment, and prescribing safely. Thanks very much, Hassan. Welcome.
Thank you very much, Trudy, and thank you very much, everyone, and good afternoon from me, and I hope you're having a wonderful webinar. So I've been tasked by the team to speak about vitamin D use in pregnancy. So I will give the talk, and then at the end, we'll have some time for discussion. So let's remind ourselves of how vitamin D is actually manufactured in our body and how we can get the best of vitamin D for its function. So it is a lipophilic vitamin. So it's what we call fat-soluble vitamin, kind of the way we say it. And there are, of course, water-soluble vitamins. With fat-soluble vitamins, it's always important to remember that having too much may be harmful. And the fat-soluble vitamins are vitamin A, vitamin D, and vitamin E. As you know, vitamin A could be quite seriously damaging to pregnancy, while vitamin E probably less likely. But vitamin D on high quantities could be harmful as well. So we need to make sure that our pregnant women and breastfeeding women are taking the right dose. Now, how does it work? So I would say that if we look at it, we take the vitamin D mainly from sunlight, where some we also take it from diet, and then they go to the liver, go to the kidney to get manufactured, and then we can use them. So I'm going to show you a short video of how this works. So you have to think about vitamin D as a hormone that plays an important role in calcium absorption and bone development. And it is naturally produced in the skin. So you can see the sun there, sending the kind of the UV light to our bodies. And that pre-vitamin D3 it becomes kind of converted to the body. On the food sources, we have vitamin D2 and vitamin D3. So the vitamin D2 come from things like mushrooms, while vitamin D3 will come from something like fish. And therefore, this will go to the liver and to become biologically active. And there vitamin D is hydroxylated into what we call 25-hydroxyvitamin D. And then it goes to the kidney, where it gets converted to produce 1,25-dihydroxycodeine. And this is also known as calcitriol, which is really what actually gives us the vitamin D that binds to the receptors and make us have good absorption of the calcium. And there, together with that, goes and form the bone that we need. So that's kind of how kind of vitamin D works in our bodies. So sun, fish, and other sources, but the best is really from the sun and from the fish. So what is the clinical significance? So bone metabolism is important, as we said, but also it is supposed to help the immune system. So it's really quite crucial for immune system modulation. So one of my areas of expertise is I look after a lot of women with recurrent miscarriages, and it's really important for these patients to be on the right dose of vitamin D in general. So it's really crucial to do that. So you can see here that if you have enough sufficient amounts, then you'll have strong muscle coordination. You reduce a reduction of incidence of fractures with falls, and that's particularly in the elderly. But remember, a woman who goes through pregnancy, all that bone in the baby is coming from that mother. She's also going to breastfeed, and that will also increase the absorption of calcium from that mother. So women during their reproductive life will be vulnerable to have a reduction in their bones themselves. And it is also important, as we said, to reduce lots of chronic illnesses. And recently, the link with autoimmune conditions has become quite significant. So patients with MS, for example, patients with other autoimmune conditions are now advised to have high doses of vitamin D. Another benefit as well, in particular, that low vitamin D can become a problem, increasing the risk of malignancy, because vitamin D is actually has that kind of almost like a key when it comes to identifying in the body abnormal cells to get rid of them. So if you have low vitamin D, therefore your body's kind of ability to recognize abnormal cells drops dramatically, and therefore there is an increased risk of cancer. So this is the kind of the foods that we think of. If you look at the vitamin D2, as I've said, you will find that in kind of lots of vegetables. But if you want to look at good kind of dietary vitamin D, then oily fish is one of these one of these kind of products that you look at. However, I think supplementation is more or less required, especially in our country here, because we don't have a lot of sun, unfortunately. So how do we kind of supplement vitamin D in pregnancy? So number one is low levels of vitamin D during pregnancy has been associated. So the question is, why do we want to supplement? Because low levels of vitamin D has been associated with the increased risk of preeclampsia, gestational diabetes, preterm birth, and low birth weight. And that there is evidence that adequate vitamin D is crucial for maternal health and fetal skeletal growth, as well as optimal outcomes. And you can see there's some kind of references there if you want to look into that. And as I've said before, it really plays an important role in the innate immune system for the body to tolerate pregnancy and doesn't reject it and increase risk of miscarriages, etc. Therefore, all pregnant women should be encouraged to eat a healthy, balanced diet and to take a daily dose of what? We don't know. That's something we need to discuss during pregnancy and breastfeeding. So what does NICE guidelines tell us? So the NICE guidelines tell us that women at high risk who in pregnancy are advised to take a higher dose, which is 2,000 to 2,400 milligrams. And that's kind of confirmed by the RCOG guideline, NICE guideline, and National Health Service kind of paper on multivitamins used in pregnancy. But who are these high-risk patients? So let's go through them. Apparently, low or no exposure to the sun. Individuals are those in particular who cover their skin for cultural reasons. So low or no exposure to sun. I don't know where you guys live, but where I live, I don't have a lot of sun most of the time. So basically, if you cover your body for cultural reasons, so women who wear hijab, even at more risk. Pigmented skin, so Afro-Caribbean, South Asian women. Obesity, if you work at Epsom and St. Heliers like I do, we have found that more than 50% of our patients are either overweight or obese. And those who are low in vitamin D rich food, so no eggs, no meat. So we're telling people, don't eat a lot of meat. Some people can't afford to eat meat these days. And on top of that, when you don't have a lot of sun in your country, and if you're covered, and if you're overweight or obese, and if you have a pigment on your skin. So when I calculate that, that's almost like 80 or 90% of our patients. So, but we're still telling our women, this is what we're telling them, take 400 micrograms. I don't know where this advice comes from. So 400 micrograms is supposed to be to low-risk women, but I can't identify low-risk women when we put all these risk factors. So that's something we can discuss later on. So how much to give? Let me tell you the confusion of how we do things. So the Institute of Medicine recommends 400 to 600 international units per day. The National Health Institute, which is NICE, recommends 400 international units. They're the same people who said, if you don't have enough sun, if you're pigmented, if you're obese, if you wear hijab, if you come from Asia, if you come from Africa, the same people are telling us to give 400. The Endocrine Society says 1,500 to 2,000. And then the Canadian Society says 2,000. So you can see where the confusion is. But let me give you some advice. Number one, because some of you I know are prescribers, is that is it safe to give high dose? Because remember, I said at the beginning, this is a fat-soluble vitamin. So the Institute of Medicine said it is safe to give up to 4,000 international units per day in pregnancy. And the Endocrine Society said it is safe to give to up to 10,000. So don't be scared to prescribe higher doses, because you're not going to cause toxicity of vitamin D by giving someone, say, 2 to 4,000 units a day. And that's really what is really important about this message. What about breastfeeding? There is no particular guidance, specific guidance that we have about breastfeeding. Trust me, I looked into it. But I think most people will say, do what you will do for pregnancy, because it makes sense, because all that milk that the baby is taking contains a lot of vitamin D. So you need to of calcium, and therefore you need to supplement that for the mother, and therefore you need to continue giving that. So testing, what is the normal range? I don't think anybody knows what the normal range for pregnancy. There is an assumption that less than 25 is considered vitamin D deficiency. I'm happy to agree with that. And some people say 25 to 50 is insufficient for a pregnant woman to meet the demands of pregnancy. But nobody knows where that 50 came from. I argue that from my personal investigations into what is happening on the literature, that I think that level is 80. So I think if somebody starts a pregnancy with a level less than 80, they're unlikely to meet the demands of pregnancy. But even with 50, if you start screening the women, which we don't, you will find the majority of our women actually would have a level less than 50 at the start of the pregnancy. And I can tell you that is the case, because I test a lot of my patients at the beginning of the pregnancy, and very rarely I find levels well above 80 or 50 unless they're taking high doses of 2,000 or above. So currently, routine testing is not recommended by the NHS. And only you will do the test if there are symptoms or signs suggestive of hypocalcemia, osteomalacia, osteoporosis, such as bone pain and tenderness and muscle pain, etc. And what you will do in these circumstances, you will do serum 25 OHD, and you do a bone profile which contains calcium, etc. And you will use an ease, because remember, it's part of the metabolism that the kidney metabolizes that. So how do we treat patients with vitamin D deficiency in pregnancy? So number one, you need to refer to a specialist. So, and then to find out if there's any contraindication to give vitamin D, for example, if they have renal impairment or renal stones or bone disease or anything that predisposed to hypercalcemia, some GI conditions and liver conditions. Some people say if you want to give high dose, you need to start in the second or the third trimester. I'm not sure about that, and I can't see where the evidence that for. And you normally start with a loading dose and then a maintenance dose. So this is actually some work that we did as a network together with a lot of colleagues. Some of you may be attending this, is to see what Southwest London should be doing at the primary care level as a first line. And the recommendation is that you do a loading dose of 300,000 of cholecalciferol prescribed by brand in primary care. Licensed preparations are preferred, and avoid single mega doses if possible. And then try to decide of how you do that. There is second line and the third line. I think what most people do, common practice that I do in my practice, is to give 20,000 units once a week for 4 weeks. So for 20,000, 20,000, 20,000, 20,000, easy to remember. And then you move to the maintenance dose, and there are lots of options of people preparations, 800 to 2,000. I think I will go just for 2,000 daily. So easy, 20,000 once a week for 4 weeks, and then 2,000 daily. I think that simple approach you won't forget. But if you want to look into what the preferred options and doing how you do it, there are lots and lots of different criteria. And I don't think we have a current agreement in the UK. And your consideration is that oral route is the best. Actually, there is no evidence that injections are better. So actually, oral route is very well absorbed. I'm not sure you need to give anybody an injection. And I've spoken to some pharmacists about that, and they confirmed to me that oral routes are absolutely suitable. So what about high toxicity basically concern? So there are adverse effects like hypersensitivity, for example, itching and rash and urticaria, hypercalcemia, we said that. But the signs of toxicity might be some early ones will be somebody who have constipation, feeling nauseous or fatigue. That sounds like pregnancy to me, so it's very difficult to note. But late consideration will be bone pain and renal damage and psychosis, which is rare. And in these circumstances, you will stop the vitamin D and rehydrate. I don't want to scare you, because I think if you go back to what we said, giving 20,000 per week if somebody's iron deficient, vitamin D deficient, once a week for a month, and thereafter that 2,000, I don't think you will have any problems with toxicity. I've never come across toxicity personally in any of the patients I've looked after. And then the follow-up treatment is then if you want to check their calcium levels, and after completing a high dose, you see what the levels are. And then you can do regular monitoring with looking for kind of signs of malabsorption or non-compliance. Therefore, sometimes you may need to do that, but that's normally not required in these patients. And of course, then advice about lifestyle, dietary intake, for example. They need to improve their oily fish intake. But the best thing to do is to advise them to stick to their vitamin D supplementation and have exposure to sun when there is a sun, which is not really common. Commonly we have here. So really the questions I have really for you at the end of this talk is, should we change practice? Number one, do we need to check vitamin D level during pregnancy? I would say, personally, I don't think there is an indication, because lots of studies have shown that most people are at the vitamin D deficient. So I think the only benefit of doing that if somebody is symptomatic, and we've agreed that we don't really know what the normal level is, but that's something we can discuss at a local level in each unit. If you're going to decide to do that, then decide what your cutoff is and act on it. But if you start prescribing people, then you need to decide what doses you're going to give them. So for me, the level normal should be for pregnancy should be 80 and not 50. And then do we supplement all women? My answer is absolutely yes, and giving them 2,000. So my argument would be that if you are going to give 2,000 to 4,000 units a day, then you don't need to check a level at the beginning, and you don't need to know what the normal range is, because you just give everyone 2,000 because it works. And a lot of studies have shown it works. And then the last question is, do we prescribe 2,000 or more? And the answer is yes. I think giving 400 units is too low, and it doesn't work in the UK. We don't live in Dubai, guys. I don't know if you discovered that. We don't live in the Caribbean. We live in a very cold country with not much sun, and we have a lot of obese and overweight women. We have a lot of Afro-Caribbean women and Asian women, and we also have a lot of dietary issues because of the sources of vitamin D. So I think for all intents and purposes, my advice will be just go ahead and give everyone 2,000. Thank you. Questions?
Fantastic. Thanks so much for that. I really particularly enjoyed that last slide on should we change practice. It was excellent. We have got a question. How long after starting treatment do we retest it? And how often for people that are already on supplements in pregnancy because of known risk factors or deficiency?
So I think the current recommendation, so let's reaffirm what the current recommendation is. The current recommendation is 400 international units, which is 10 micrograms. I think I have made my case for the fact that this is not enough. When we look at our population and we look at our weather and we look at our diet. So I think personally, 2000 would be the right dose. If you're talking about preventative prophylaxis, then give 2000. If you're talking about treatment as this question, so if somebody's vitamin D deficient, I don't think as a midwife you'll be dealing with that yourself. But I can tell you, then if somebody's deficient, i.e. the level is below 25, then you need to give them 20,000 once a week, 20,000 once a week, 4 times, and then 2000. I'm just a simple person, Trudy. I can't remember things easily. So for me, I'd like to make a link, 20,000 and 2,000. That's easy to remember. So if you take 20,000 once a week for a month and then 2,000 daily, then you're fine. The only reason that you want to monitor to see the levels again, as I've said on the slide, that if you're suspecting lack of adherence or compliance of taking the medications.
Do you think the guidance will catch up anytime soon?
It should be. It absolutely good
time.
question, Trudy. It just blows my mind. I think there is something about vitamin D that people don't, I mean, powers that be don't really act on it for some reason. I'm hoping now with the change of government, there will be a change of heart and we start kind of exploring the possibility of changing the advice. So the majority of the European countries advise 2000. And I don't think our weather is much better than them. Canadians, as we've shown already, the Endocrine Society as well. And if we look at our multicultural population that we have in the UK, together with the high prevalence of obesity and overweight, and add to that the kind of the limited dietary intake of vitamin D, I can't see any reason why we can't revise our policy. I mean, the NICE guidelines on one hand and say, give higher dose to those patients categories 1, 2, 3, 4. And then for normal people, give them 400. I don't know where these normal people are, personally.
Yeah. We've got another question in the chat. Are there any group of pregnant women that you would not give vitamin D to? I.e., I've got an oncology patient, and what's the difference between D2 and vitamin D3?
So D2 is mainly present in vegetables. D3 is the one gets converted by sun, or you get it directly from a from oily fish. Eventually, they all become the hormone. So they're just the way the metabolism kind of bypasses. So there are certain groups that, as I mentioned, so patients who have, for example, you need to know about patients with say, hyperparathyroidism, for example, patients with certain liver diseases, patients with renal disease, because it is part of the metabolism. So these categories, you need to be very careful of giving them extra vitamin D. So you need to liaise with their clinicians of whether it is safe to give them higher doses of vitamin D. I think the doses of 2000, I don't think it matters. But if you're going to want to give somebody higher doses, treatment doses, either a one of 300,000 or 20,000 every week, then you need to have a discussion about those patients.
Great. Okay, thanks very much. That was a brilliant talk. That was excellent. And I'm just going into closing statements now. So I was just going to say thanks to Carolyn and Derry and Emily, who put so much work behind organising and running this day. And I'm sure you can echo that for us, Professor Shehata, because it's there's very little funding for it, as we know, but the generosity of the speakers and people of their time to step into a day like this to give their knowledge helps us as midwives grow our expertise, which is fantastic in supporting women with medical complexity. So,
I agree, Trudy, and I think I would like to say thank you very much, of course, for Carolyn, who obviously put this amazing program, and the team as well, Karen, Emily, as well as yourself, of course, Trudy, and everybody else, Joyce and Catherine, and of course, Dermot, who's behind the scenes doing all the IT stuff. I think our network is really keen to continue providing such fantastic educational opportunities. It is a shame that we can't do it face-to-face at the moment due to funding issues, but my hats off really to Caroline, who keeps persevering and getting us kind of having these amazing programs. So really grateful and fantastic program, and congratulations. And I hope everybody has enjoyed it, and fantastic sharing from you as well, Trudy.
Yeah, thanks very much. Okay, so I was just going to say to the attendees that Joyce's presentation earlier that we had, Joyce was discussing UTI and pregnancy. We cut Joyce's presentation off a little early due to timing, but Joyce has reassured us, we've caught up with Joyce, and she's going to send over the recorded session. And I'd just like to say that it's worth watching, so please revisit the platform and watch the rest of Joyce's presentation. I learned everything I know about renal disease in pregnancy from Joyce Papula. She's a passionate clinician. She's a strong advocate for kidney care and pregnancy. Her expertise is definitely worth tapping into on that presentation. The other presentation we're going to have uploaded that we didn't have the opportunity to listen to due to audio technical issues was Layla Mayahi. Again, has so many skills, and particularly in clinical pharmacology as well. So that session around prescribing in pregnancy would be excellent. Did you want to add to that, Has? You've got your hand up.
And when you finish, I just want to plug another meeting of mine that when you finish.
Okay, thanks. Yeah, I'll carry on for a little bit longer. When we're closing the meeting, a QR code will come up, and that will be for a short survey monkey. And if you could complete that, that really will help the network in demonstrating the efficacy for increasing midwifery expertise, and give us an idea of numbers and people that have benefited. So please, if you can just take a few minutes to complete that, that really helps. Apologies again for the technical issues. There was an issue, we've confirmed it now, from Zoom USA. So we had a Zoom itself, which is the platform we've run this day on, had their own technical issues, which have caused an issue in this study day. So apologies again for that, but thanks for your patience. And I think you'll see that in the afternoon, we managed to get most of that back on track. The link to the platform where you can revisit the presentations of today will be in this end slide, and they will be uploaded in about 3 days or so. So have a look at that then. Again, I just wanted to thank the backup team who've been in my ear and on WhatsApp, Caroline, Emily, Derry, and of course Kat, who was also there. And a huge thanks again to the expert speakers that so generously gave us their time. So that's my final closing statement. So I'll pass over to you now, Has, for your last words.
My last plug. So some of you may know that we've been struggling with perinatal pathology these days. So a lot of babies are now having to, a lot of families having to wait for postmortem results for months and months. So in my role in the Royal College, I have set up a webinar on Wednesday, the 25th of September at 6:30. If you go to the RCOG, there is a big webinar between the Royal College of Pathologists and the Royal College of Obstetricians, looking at the criteria of referrals and how we can improve our referrals, because we are struggling with perinatal pathologists around the whole country. So if you're interested, some of you, because you are the first stop where you decide who needs to go where, please join us 25th of September at the Royal College webinar. If you go to the Royal College, you will find the link there. That's all. And it's free of charge.
Great, thanks. So I think that brings the Prescribing for Pregnancy Day to a close. Thanks again, everyone, and hopefully see you again soon.